mainly the only instrument we had when I started my career was a diamond burr.
You graduated in Zurich and you shared a very interesting time with the great Peter Scherer. You've been leading the Department of Fixed Prosthodontics in the University of Geneva for almost 30 years.
You're also very adamant about respecting nature.
At one point in time, was it clear for you that you would like to enjoy a career in academia?
When I did my doctoral work, I had to do a scientific work, so I started with that, and I loved also this. And what finally made the decision, when I got a stipend of the Swiss National Foundation for Research to spend 2 years at UBC in Vancouver, in Alan Hannam's neuroscience lab. That was the best.
Welcome to ProTalk, welcome to the Pulse of Dentistry, welcome to this episode that George and myself were very much looking forward, because we have a very special guest today that we can welcome. This is Professor Dr. Urs Belser. Urs, very much welcome to be the guest in our podcast. We are very honored that you came over to Basel and that you are our guest today.
Thank you very much for this invitation, and that I have heard a lot about these podcasts, and I watched a few of them, and so I feel deeply honored to be part of it.
Great to have you.
So from a more personal note, Urs, I mean, who is Urs Belser in 1 minute?
You must be aware that I'm coming from the area of gnatology, and where mainly the only instrument we had when I started my career was a diamond burr. And then I, overlooking now roughly 50 years of evolution in reconstructive dental medicine, including also implants. And I think that is something which makes probably it worse for you to discuss a little bit the journey. Now I am almost completely retired. I have to admit, I'm enjoying it, a lot of it. You know, what usually goes with retirement: more time, family time, grandchildren, playing golf, fly fishing, traveling. So there is a lot of that. But still, my enthusiasm of clinical dentistry is still intact. Yeah. And I'm still following the evolution, because it's passionating what we are facing today.
And you're still lecturing every now and then? I know that you get invitations.
Occasionally, but I really, I don't like huge podiums anymore. It stresses me. Like this stresses me also a little bit, but it should be okay. No, what I like is study clubs and smaller meetings, and particularly what I like is the graduate students. I can still give some seminars at the University of Bern and University of Geneva, and this is always a huge pleasure with a small group of young, enthusiastic, curious people. Yeah.
To exchange thoughts. But starting from the very beginning, I mean, has it always been clear for you to go into dentistry? Like, was this part of your family, or how did you actually end up in dentistry?
Good question. Nothing spectacular. My father was a dentist, okay. and he never pushed me into dentistry, but he took me when I was a child to his practice. I could watch the laboratory, also the work the technician made, and then occasionally when he was treated a member of the family, I could watch, and immediately it appealed to me. And then I went into medicine. The first 2 years are together with the medical students, and I never changed my opinion, and I straight went on to dentistry, and I never regret it.
And the history with your fathers is also why you have such a high opinion and, let's say, respect for dental technicians, because this I always felt very special about you, that you had such a high respect for your dental technicians.
Yeah, it's nice to mention that. This I have not only from my father, but from Peter Scherer, my academic teacher and chairman at the University of Zurich. He always said the dental technician is an integral part of the team. and he should have access to the patient. Because if you want to get his best, then you must give him this, that he really feels concerned. And that we did from the beginning. And throughout, when I then look at Alwin Schönenberger and Michel Mania and Pascal Müller, it was a pleasure. And I always got really the best they could do because they knew I was highly respecting them. And we must admit that what is visible from a reconstructive dentistry in the mouth of the patient is what the technician has done.
Exactly.
And makes a difference.
I think you also show in your presentations always basically this appreciation of the dental technician. And I think that really stands out, the understanding of how important this collaboration is. And, maybe you can allude a bit more on how it also affected your career, this very close collaboration with dental technicians.
Yeah, I learned a lot from them because they wanted to be able to copy really what nature does, and then you see how they stratify the ceramics, and so I got a lot of respect because they could do things which I probably would not have been able to do, and that's why I'm also a little bit surprised that now they are a little bit worried. Because they say, is our profession not going to disappear because all of these digital things? Then I think they are wrong. It's an opportunity for them because they know exactly what is needed. And I don't think that the dentist will now do everything himself on the computer. They will do it better. And I think it's an opportunity for them. And I always tell them, it will go on.
I'm fully with you, and I hope that a lot of people see it like you and have this respect for the dental technicians because it's this combination of technology, craftsmanship, of art, and creativity that really makes, let's say, a unique outcome that you presented very often in your cases on congresses, right?
And this can be translated into digital technology.
Absolutely. Yes.
Absolutely.
And there will always be things that dental technician can bring in that technology will have a hard time to bring in. So I fully agree. It's an opportunity for technicians rather than a threat. So we know how you got into dentistry, thanks to your father. At one point in time, was it clear for you that you would like to enjoy a career in academia? And not follow your father into his practice, maybe?
No. I actually, when I went into graduate studies, I did not think I wanted to go into an academic career. But as graduate students, we also had, I think, 2.5 days per week. We were assigned to the student floor where we should supervise their practical work. I loved it. This is really, this is something very rewarding because then you have an age group of young people who are really motivated. They want to learn because they know it's what they're going to do later on. So was easy. I loved it. So I thought this I want to keep, even if I would go into private practice, maybe 1.5 day per week, go to university and supervise students. Then the next step towards academia was when I did my doctoral work. I had to do a scientific work, so I started with that, and I loved also this. And what finally made the decision when I got a stipend of the Swiss National Foundation for Research to spend 2 years at UBC in Vancouver in Alan Hannam's neuroscience lab. That was the best. I could learn electromyography, jaw movements. We were still in the area of occlusion and articulators. So we made studies on the jaw movements related activity of the masticatory muscle, and we tested different occlusal schemes like canine guidance or group function or the impact of non-working site interferences on the coordination of the muscles. I thought that was really something interesting. And from then on, I thought the combination of teaching, research, and clinics is just fantastic. So I can only recommend. There are some sacrifices to be done, that's for sure, but it's worth it, more than worth it. Yeah.
So, and how did you end up then in Geneva? Was this like a natural opening? And
No, that was my boss. I was still in Vancouver, and he called me, "Oh, the position in Geneva is open. You have to apply for it."
Now.
Yeah. And then I said, "Professor, I'm not ready yet. And it is in French there." He says, well, don't worry. Go there, apply, and so you once have experienced how such a competition goes. And then you will be prepared for later. And then, of course, I wanted to make a good impression there. I really prepared my lecture and the interviews. And to my big surprise, they took me.
Okay.
I was only 35 years old at that time and became department chair. And they welcomed me so kindly in Geneva. So I really never regret. My wife regretted a little bit. She loved to stay in Zurich.
Maybe to close this chapter, if you look on the young generation, that I'm very happy to see that you're still connected to these students and you have this conversation and time with them still. What would you recommend to the next generation of dentists, how to shape their future and career?
Yeah. That's an important question. Of course, I would encourage everybody who has some doubts if eventually academia would be something, start with the graduate training. And during that, you will be exposed to all the facets of that. And then find a field of interest for you. And because what I am, or what made the reputation of our department is based on teamwork. It's the young people who come, and they are not biased. They come with new ideas and enthusiasm, and you have just to create an environment so they can develop their talent. And I saw that so many times. I don't know if I can dwell on that a little bit longer, but when I think at Herman Gallucci, he came to Geneva out of a private practice in Argentina. And suddenly he heard about the ITI scholarship program, and he applied, he got it. And 5 years later, he left to Boston, to Harvard, worked with H.P. Weber another few years, and now he is head of department at Harvard. This is incredible. I skipped a lot of
steps,
details. But he was, of course, very talented and also very ambitious to reach this goal, but an amazing career. And I could quote many of the ITI scholars who passed for a year and then stayed and then became instrumental for the development of the field of implant dentistry.
There's no doubt, let's go a little bit to your work and research work. I mean, there is no doubt that you are the father of many concepts in prosthetics, but also especially I think in implant prosthetics now. I mean, looking at all the work that you did and all of the research work, you are more than 30,000 times cited with your publications. Is there any publication that you look back that you say, look, this is really one that I'm super proud of, and that was a bit of surprising also the results?
Here I have to insist once again, what we have achieved is the result of team. There are many people who are not mentioned. I have to pay attention that I give credit also to those who deserve it. But achieved, I think we really developed aesthetics on implants. That because I remember at the beginning, osseointegration was almost a miracle. So one tolerated that it was not perfect which was on top of the implant. I heard so often, well, it's not bad for an implant, but that already means it is not a perfect illusion. And I think we systematically approached this field to look if we can come up with decent restorations on implants in the aesthetic zone. That was certainly a nice contribution. The other one was to in the field of not implant dentistry, to try to be less aggressive. And then that brings us then maybe later to biomimetics, an approach which was really an eye-opener for many. So, because as I mentioned that before, we were crowning so many teeth because the only tool we had was the burr, and we had retention and resistance form and full crowns. And then this did not satisfy. We realized that we are maybe too aggressive. The biologic price was too high. And there, I think we contributed significantly that this has changed over the years.
Yeah. So you touched already, and I think we come back to the topic of biomimetics later. And I think you have spearheaded a concept there, which is minimal invasive dentistry, which is today it's in everybody's mouth, and it's kind of maybe obvious, not yet perfect, but something that is a big trend. But you've been instrumental and also a pioneer in implant dentistry and implant prosthetics. There's no doubt. I think you helped also to progress the implant material up to a point. And I like what you said. You always were looking for this perfect illusion. And I remember when you were on stage, you often said that that's a quite decent result.
Yeah. And we could not see the difference anymore.
And people people in the audience would smile because they said, look, I would never achieve a result like Professor Belser because it's almost a perfect illusion. But, this was not clear from the beginning. When you started with implant dentistry, it was not experimental, but it was more functional. Osseointegration was solved. A lot of topics were unsolved. What have been the big milestones in the development of implant dentistry for you? And, milestones where you then thought, okay, now it's really working.
Okay. Well, then let's go back to the end of the 1980s, where I remember the head of surgery in Geneva came to me and said, Urs, we had so bad experience with subperiosteal implants. We hear now that there is somebody in Sweden who seems to have nice results. Can you not take over this part and introduce it to the dental school? And so we went to the Brennemark clinic to watch, and we were absolutely thrilled, and then came back, but the Swedes were quite arrogant to us. They say all the research has already been done. We said, well, we as a university we would like to participate to studies on that. No, everything is already done, and you just can buy the system as any other clinician. And we then heard that there was also somebody at the University of Bern, which was Andre Schröder, who had a very different approach. And we invited him, and he immediately convinced that was the way to go. He has a very different approach, non-submerged surgery, and then a prosthodontic procedure pretty similar to what we are used to do on teeth. This appealed to us. We, with Jean-Pierre Bernard, that was the surgeon at the University of Geneva, we started very cautiously, anterior edentulous patients in the lower jaw with 2 implants, non-submerged, and then spherical attachments or bars, and we just felt comfortable with that. Then we moved gently to the partially edentulous patients in the posterior mandible. We placed the implant very superficially, so no prosthodontic interfaces deep into the tissues. And I still remember that was still the nicest soft tissue around the implants we saw, because no margins were there. But obviously we were cementing the restorations, crowns and bridges very successfully because everything was under control. And then came finally the moment where we wanted to also use these implants in the anterior maxilla. And there we thought, no, we cannot cement there because they are rotation symmetrical and interproximally we would be so deep. So we need screw-retained restorations. And then we developed the Synocta system. And then we were using these tissue level implants at that time very successfully, also in the aesthetic zone. I must say, we did a lot of those and it worked, but we realized it was certainly not the last word in development of implants. And so that was how, and then, of course, came the bone level.
2004, 2005.
Yeah. So I'm really jumping ahead very much, but that was something very exciting because before that, it needed to be proved that the non-submerged system is exactly as reliable or predictable as the one, because it was a dogma from Gothenburg at that time that you needed to submerge. But we didn't want to admit by making bone level that the assumption was wrong. So, but at that time, everybody was convinced that both ways are predictable, and we could go with the development of the bone level implant system.
And how do you reflect back on this project? Because I mean, George and myself have been leading this project, and you've been a very close advisor to us. I remember I asked you a lot of stupid questions those days. How do you reflect back on this project? You did the pilot study with Danny Buser. You placed the first implants into humans. It was quite an exciting project. How do you reflect back on this?
Was a great. It was from many points of view. This was a great period. This prospective case series study on 20 consecutively treated patients, because the primary objective was, can we confirm the platform switching concept, which was claiming that you would keep the bone exactly at the implant shoulder? So that was the first objective. But Danny Buser's team had already developed also the concept of early implant placement and simultaneous contour augmentation. So this was all also implemented in that study. And we published the data then after 1 year, 3 year, 5 year, and 10 years in the Journal of Dental Research. And we could confirm the hypothesis that yes, you keep the bone if you have a non-matching prosthodontic approach on these implants, and at the same time also having a strong clinical documentation or scientific documentation on early implant placement. That means waiting for soft tissue closure before you place the implants, and facial contour augmentation. Because we were, if you allow me to say, we got the authorization by the human experimentation
the ethics
committee to make 4x4 centimeter cone beams on these patients also, if they would agree. And we could see that we could keep that, and by this 0 recessions on all these implants over 10 years. That was for me really a game changer, as you said.
That was also for us as a company was a breakthrough. This development and finally seeing that it's working out. And we come back to this project later. But one question I would also like to ask: if we speak about pioneering implant dentistry, I think we also have to speak about the ITI. How do you see the contribution of the ITI in this context?
In one word, would be major. It was a vision of André Schröder and Fritz Straumann, and then later on, or quite rapidly, took over also and followed through all these years by Thomas Straumann. I cannot say everything with Straumann, but what I found particularly decisive was this synergistic approach between Straumann and the ITI Development Committee and the Research Committee, major contributions. And then, of course, the study club system and the ITI scholarship program.
Yes.
So education, research, and brainstorming with the Straumann people to look in which direction to go, and that it has had to be approved from both sides. That was long time. Then later on, this was not possible anymore because everything grew so fast. And I mean, the ITI is now I think by far the largest professional organization worldwide, and with all which goes with that. So I could for hours still dwell on that, but I don't want to do that. But yeah,
maybe one anecdote to share to link the bone level development and the ITI, I think, is I remember still, there was we had a scientific advisory board consisting of ITI fellows that was advising us, and technically we've been ready to launch the product, but then we got the advice from the advisory board in Geneva at that point.
We had the meeting.
You guys, you cannot launch it because we see great data, but we need to have more follow-up data from the clinical studies.
I remember.
So please wait. So even though we've
been half a year more,
half a year more, even though we've been ready technically to launch a product, we did not launch it because the ITI Scientific Advisory Committee told us to wait for another 9 months. So we postponed the launch of the bone level implant by 9 months. And I think that really, this was a painful 9 months for us, but it really showed us also the power of this collaboration, because at the end it was the right thing to be done from a scientific point of view.
Yeah, because when we look back, we had never, during all this development of the implant system, never major catastrophes. Huh?
Yes.
Because we were very cautious. Always tested at least, and we said a minimum of 1 year in pilot studies before this should go to, and I think this was a safety margin which I think was worthwhile. Yes. Maybe as a company you want to go faster and you think this is slowing us down, but I think on long term it paid off.
We saw it very positive, to be honest. At that stage, being involved there, I think we saw the good intention behind this.
And it was also a strong launch afterwards. I think with this data of the 20 cases. This I still remember. When we saw this slide for the first time with all 20 X-rays.
Yeah.
And of course, it was like, okay, this is important that it's showing good results. And then finally we had I would say a strong launch. Also involving the ITI and the study clubs in disseminating the knowledge on how, and giving the trainings on how to use the product. So I think it was a good decision, but it was tough. That meeting in Geneva was like, oh, okay, now we're putting a temporary halt on the launch plan.
Yeah, we also have some community questions because we told people that we will have the conversation today, and we selected one from Daniel Wick, from I think his colleague from Hungary, and he said, I'm interested in your opinion about ceramic implants.
Ceramic implants. Okay. The first ceramic implants I was aware of, they were one-piece implants. And so I said, I'm never going to use those because you had to be very precise in implant positioning. And I still saw that people were grinding on the implants. And then, of course, the only thing you could do was restoring it with a cemented restoration. So these were all things which for me, and then also reintervention, virtually impossible. So that was a no-go. Then came the two-part ceramic implants. Then I thought it still needed a little bit of metal inside to make a connection and make all the components working in the way you would like to do that. But for me, it's still, I know zirconia osseointegrate very predictably, that's for sure, but it's still a brittle material. Then I'm aware that there are some concerns from the medical side who say, yes, it is no metal, it is better because we have some people who don't want to have metal in their body. And there I can only say, when you look in the periodic system where zircon is placed, it's part of the metal. But of course, the one which is used is white. And we always think white is not metal. So, which is not completely true also. So, so far I'm sticking to the titanium.
Implants, okay. Then we have another question from Lawrence Adrians that you might know because she spent some time in Bern. And she said, what she's writing, I have to read it. She said, look, the first time I encountered bone level implants was through a presentation actually of you. And obviously it made a change to her and her department and they adopted it. And it was for them a breakthrough also to starting working with bone level implants. And her question is, how do you look at the recent developments of the Straumann system with BLX and BLC implants? Do you still follow this? And
I follow this very much. Of course, I have conversations about that with Danny Buser almost every week. But my point right now is that it would appear that the TLC and TLX are for me the perfect synthesis of the last 30 years. Because I said I was a fan of the tissue level implants in the posterior part of the mouth because I had no margins in the tissues. So this was given away suddenly that everybody switched to screw retained restoration and placed the bone level implants all over the place. All over the place, yeah. In situations, and I understand that in a private practice you don't want to have all the different types of implants. You want to streamline a little bit your approach. So I could understand that. But when I look at what is relevant today, that we saw, or worldwide one could observe more peri-implantitis cases. Not especially on Straumann implant, but worldwide it became really a problem. This has various reasons why this is so. But that's why this development is now that we have still a machined top of the implant. We can still put it in a little bit into the bone there, but we will have very little adverse effects. If this surface would once be exposed, we will not have the same problems as we have experienced with the micro-rough surface being exposed. And fantastic is that we have now 2 prosthodontic approaches possible on the same implant. This is just fantastic. I think this is, for me, really the perfect thing. But we can still, for the time being, I think this will work for quite some long time. But will certainly not be the last word in implant dentistry.
I agree.
I cannot even. But for the time being, this is by far the best approach, and I hear from the clinicians that they are so thrilled about this, and that was a major contribution of Straumann.
So a strong vote for the TLC and the TLX implants in this case. So thanks for that.
No, this is really a masterpiece. I must say that. I hope this will be confirmed by the broad use, but it looks so logic. Danny calls it a hybrid implant, but and also when I look, we started with the Morse taper, and the anti-rotational feature was only on the secondary component.
On the prosthetics.
Then was Synocta. We had an octagon, 8 different positions, but quite tricky to find always the right. Then was the CrossFit. Was fantastic to use. It was touch and feel. It was deep in the tissues, but you knew exactly, you turn it and then you fall in. You knew you didn't need any X-ray controls. But still, a little bit limited because only 4.
You needed A and B components.
And now you are to 6, to hex again. But absolutely perfect connection. Virtually no micro movement, and also the precision. If you have a peripheral margin, so precise that we have much less a micro gap, much less effect on saucerization, and also that you have no micro movement. Also, this contributes that we have much less bone resorption. So a masterpiece. I really must say that.
We still have a lot of ideas what to do else. But
Exactly.
yes.
No, thanks a lot for the
Thanks a
feedback,
lot.
and it means a lot. And
I'm not only saying it
doesn't-
because I'm sitting here in a room of Straumann, but it is my honest opinion.
And it feels like you're still 100% on it. It's very impressive to see how you follow all these developments, and yeah, good. So now let's talk about some of the concepts that we touched already upon before quickly. And I'd like to start with biomimetic restorative dentistry. So in 2002, if I'm not mistaken, you brought a book out together with Pascal Magnier, which is describing that philosophy. And it's a really minimally invasive and biologically mimicking approach to only touch upon teeth where it's absolutely needed. So very reducing the invasiveness and making the best out of biology. Can you explain a bit how that concept developed and why it is still important today?
Yeah, I like to, but I have to put first Pascal Magnier here in the picture. This is one of the most extraordinary talents I've ever met. And can you imagine? He was a dental student already there. He came always with difficult questions, and when he applied then to make his graduate training in our department, we just were thrilled about that. And I could follow really this young personality. And to come now to your question, this term of biomimetics, it started, but that Pascal wanted to look, can I really come very close to the perfect illusion on crowns? That's how it started. And he had a very talented technician brother, and so together, I remember they brought a lot of extracted incisors, and then they really photographed them. Then they removed the enamel to look inside what is really the details of the dentine underlying to make this appearance which we all know from a natural tooth. And then his brother very rapidly was able to copy this almost perfectly under different optical conditions, so perfect optical illusions. And then it went further on that Pascal made research in Minnesota for 2 years. And to make a long story short, before that period, we thought we needed the strongest material to restore a broken down tooth. And quite often we had to devitalize the teeth to get adequate retention and resistance form. So we were using posts, and the strongest and the longest, the better. And also the material, the ceramics, very resistant material. We thought that was the way to go. But still, we saw fractures. But we saw always bad fractures that when it fractured, we lost the tooth. And then Pascal came with this, we have to look a little bit more what really nature does, because it's amazing. Our permanent teeth, they come into our mouth when we are at age 6, and we still have them at age almost 80. It's an unrivaled success story. And why is it so? Because if the tooth would be only made out of enamel, which is very, very brittle, it is actually the weakest ceramics we have in dentistry is the feldspar ceramics. It is way stronger than that. And if the tooth would be only made out of dentin, it would not resist very long because it's a hostile environment, a human mouth. So why make it, when they are together, it's such a success story? Because of the dentino-enamel junction. This is a miracle which nature has done. Can you imagine? We have stem cells when the embryo develops, which have the potential to create ultimate tissues like a tooth. And this junction makes that the tooth is performing so extraordinarily well. And what could we learn from that? The one which comes closest to dentin would be composite. and the one closest is the weakest ceramic is feldspathic, and how to put them together. We need adhesion. The hybrid layer, the development of it. And so that is the whole story about biomimetics, not more and more less. We try to be inspired and where it's applicable, and that's only applicable on teeth, that we try to avoid whenever possible to make crowns with strong materials, because we know that this can, to transfer this into the field of implant dentistry is something completely different. Mm-hmm. And we don't want to develop now theories. It is a mindset that you try to get inspired what nature does so successfully. But don't expect now a huge of evolution of that concept anymore, because there is not more on it, in my opinion. Mm-hmm. It's just that.
So you're also very adamant about respecting nature. I think this is something that you're very, you have strong opinions on. And I think here, Andreas, you also had a very interesting conversation with Urs. Maybe you wanna ask the question, because respecting nature has also to do with what type of requests are patients actually coming with to the dentists.
I think I was always very impressed, not only by your goal of mimicking nature and creating the perfect illusion, but also your sense of perfection. And not having the willingness to do to compromises. And I remember once you told me the story that a very famous patient showed up in your practice and asked you for, in your opinion, maybe an unreasonable ask to have a very aesthetic outcome. It was Michael Schumacher at that point, and I think a lot of dentists would have loved to treat him. But I remember he came with a very aesthetic demand, which you found from your concepts probably unreasonable. And
well, he was really a gentleman. That I must just put at the beginning. But of course, sometimes when you look in the mirror and you see some imperfections, and then they ask you, "Can you not make crowns?" And then I really don't compromise. I say no. I will not cut down healthy teeth. I did it so often at the beginning of my career. I will just not do. You will find a clinician who will do it, will be willing to do it. One can with crowns make everything uniform, but how long will it last? Or what is the biologic price you pay for that? And so there I tried as much as possible not to compromise on that.
But at the end, he came back because you convinced him about your philosophy.
He did. I could convince him.
He listened to your advice.
Not everybody is perfect, but it's natural, and that's something which appeals a lot.
And I think that's a very strong testimony for how you actually live this biomimetic philosophy, and also respecting nature, and not just providing any type of restoration.
Yeah. It's not only respect; it's also observing. And if I have the possibility to come close to that, then I do that.
Now let's also look a little bit in advancements in materials and technologies. So over your very impressive career that spans 4 decades, 5 decades almost, you have been in contact with a lot of changes. And it started with, for example, moving to all ceramic restorations, then CAD/CAM technology. Now later came also the digital planning of restorative components. Now latest is AI. What were some of the most important technologies that you advocated for very early on, because you thought this will change dentistry to the better?
That's a difficult, because it came so slowly. It was not just a moment, but I realized that that ceramics was something which was aging very well in the human mouth. If you master well occlusion and many other parameters, which I can maybe not dwell on them now. And on the other hand, we had the polymers, which are much easier for handling and also for reintervention. And for a long time, I thought the polymers will make the race. the latest generation of composite blanks, which are already stratified, and subtractive approach by milling. That is something which I thought, because they are industrialized, produced, have no flaws, and that was something which I thought was really the way to go. Mm-hmm. And I was completely surprised when I realized that also 3D printing is, because I thought will never be possible in ceramics. Because when I saw how Michel Magne and all the technicians, how they stratify, how complex it is to make all the effects they wanted to make it naturally looking, this with 3D printing, I thought this was really for surgical guides and temporary restorations. But now, to my big surprise, I realized that no, it is possible also to make 3D printing. And so in this field, we will see a lot of evolution in the very few years to come. Mm-hmm. And this helps that we are less dependent on the individual skills of a technician by manual skill. But we need his skills to direct the machine to do that. But if a machine can do it, then it's of course much more predictable, and it should ultimately needs a lot of learning curve and equipment, but ultimately it should make the restorations less expensive. That's still my dream, because I'm a little bit worried that many of the tools we are using today are without reach of a big part of our population. Mm-hmm. And there I have to make an additional comment also for the young, because we have now so many tools, attractive tools to treat different problems in a human mouth. That we have sometimes problems to see the woods for the trees. The trees are all the different instruments we have, technologies, but the tree, the woods, what is it? Why are we dentists? I have to say that. Yeah. What is the population expecting from us from the dental profession? Very simple. We should promote and maintain long-term oral health and oral function. It's as simple as that. And we should only use tools which go into that direction. And that is the most important. So knowing this, what tools do we have? We want to be predictable. That means we want to have evidence. I have a problem in the mouth. How gonna solve it? Do I know it will work? That is number one. Number two is try to be as conservative as possible. Not always replace what is missing, but keep what is there. That's for me. Then no low risk for clinician and patient, and be cost and time efficient, and always keep a door open if something will go wrong. These are the 5 criteria which really count. And to put it in a very blunt way, the most important today, because we have so many possibilities of treatment, do the right thing. Once this has been confirmed, then do the thing right. Main execution also, particularly in the field of, now we go back to biomimetic, to adhesion. You have to do it meticulously, stick to the protocol, then it will work. And then, if you want to be perfect, cost and time efficient.
Yeah, that's a perfect segue. Yeah. So in your view, or maybe what is your vision on how we could further develop, on one hand, prosthodontics, but also restorations on implants for the next 5 to 10 years? What sticks out for you, and what could actually be major changes that are coming?
Good question. If I think about the level you have reached now with implant design and prosthodontic components and everything, I think this will be valid for quite some time. I do not expect a quantum leap in the next 5 to 10 years. Look, it's always difficult. I learned early, make predictions is very dangerous. If you people say if you want to really make a fool of yourself, make predictions. Okay, so I don't want to do that. And what I also realized that the more experience you have, the less visionary you become. That's why I'm always say young people who have not all this experience, they come with fresh ideas. They are not polluted in a positive way by experience, and they can imagine things, and then suddenly a breakthrough or a breakthrough can come. People like me who have a lot of experience, they've seen, so they are not the best person.
And you have also seen fail certain things, right?
Yeah, I've seen failures also, and a lot of things which are bit. But look, we could imagine, and people have done that, a periodontal ligament. They can then not call it a periodontal ligament. It's a peri-implant ligament with the main ingredients of the natural tools. I mean, proprioception, little bit of resilience. That would probably be...
That would be a major breakthrough.
That would be a major breakthrough, but it has been tried. I remember that Carrying Man said in an animal study, he broke a tooth when he wanted to extract it to place later on an implant, and he left a little root tip in there. And then he still placed the implant in contact. And then the periodontal ligament crawled up.
Tried to crawl up, yeah.
No, it covered the implant because...
Wow.
Yeah, but from that to have a functional peri-implant ligament with proprioceptors and all this, we are far away from that. That's why...
but it's an interesting vision.
If you want to say what's happening the next 5 to 10 years, it is probably the most refinement will be on the restorative part for implant. That means digital technology, from planning to placement of implants to also to fabricate. There is still a lot of things to do to make. You are on the way, and industry is on the way on that, but still not that easy. But
and that brings me maybe to my last question from that section. So we also heard a lot about your, I would say, respect for dental technicians. And now we also see with digital technology, there is a lot changing. And you talked about 3D printing before, and we see ceramic 3D printing, multicolor ceramic 3D printing really move into realm of reality. So this is going to happen in the next couple of years. What would you recommend dental technicians on how to be best set up for this type of future?
Yeah, start with equipment that is available today. Of course, there are so different companies and which have a little bit different approach, and the problem is how much you want to invest, and suddenly it is outdated and another way. Just watch and talk to your colleagues and like in study groups, they should also dental technicians should gather in study groups together, or we should integrate them also. Some study groups do it, but that is the best, because that's how evolution will take place. To give a precise advice for technicians, how not to miss the train, I would have problems to formulate this.
Urs, thanks a lot for sharing a lot of great insights and success formulas that you distilled it down to. I know you also brought a question, because we also want to give you the opportunity to ask a question to us.
Yeah. We quite often hear on dental conferences that some of the speakers say, well, this is only marketing hype, be careful on that one. And it's true that when I look back 30, 40 years, medical companies in the medical field in general were very discreet. They were, of course, talking to the clinicians, to the healthcare providers, but not to the patients. And now I see that, and this is not Straumann, but I see some companies who try now to directly focus on the patient, that the patient may put pressure on the clinician what he thinks he should need. And so this marketing hype, it is a negative term, is something I would like not to see. And would you define as being helpful and decent marketing, which a company needs marketing? There's no doubt about that. No.
I can take this, George. I think it's a really good question. And honestly, I mean, we have a lot of specialists in marketing, and it's one of the most difficult ones that you could ask, because there is a lot of different layers to this. I think if we start, in the field of, let's say, the healthcare professionals, I mean, it's a crowded space, the implant dentistry. And I think marketing became more important, and we need to make ourselves seen. But I think what is really important is that whenever we have a new concept, a new product, a new workflow, we market what is really true, that there is continues to be data behind, and, we are not committing something that at the end we cannot keep. So I think this is really important that we stick to an ethic approach here, that we really try to spearhead this. But the other topic and the other layer you mentioned is that the patient layer, and that's a very interesting one, because the truth is, I think today, that a lot of patients are still not aware about implant dentistry. So it's a fine line, I think, making patients aware that there is implant dentistry. And yes, for maybe the problem that you have, implant dentistry is actually one of the options. So please go and ask your dentist if, in your case, it is an option. But I think we should not try to teach the patient on how it's been done. I think this we really have to leave to the healthcare professionals. Is this a case that can be done by implants? Could it be done like an intermediate approach? Yes or no? I mean, this is not the patient that should be marketed to. I think we need to leave this to the healthcare professionals at the end to direct the patient to the right treatment. Is it an implant or not an implant? And if it is an implant, what is the best approach for this patient? I think we have to keep the patient out of this. But I think educating the patient probably makes sense, that implants exist, and the best way probably still is to do this through healthcare professional. And I imagine it's also not an easy job as a healthcare professional to educate the patient. So I think here we might also give tools and help the healthcare professional to do a good education of the patient. So it's a tricky question, but I think having an ethical approach still is important. And I think for us as a company, we spoke before the podcast about this. I think we are publicly listed company, but still, we have owners that are very close to patients and that put a lot of emphasis on an ethical approach, like Thomas Straumann, the family, people like Rudi Mark. And this gives us also, I would say, the stability that, we can have an ethical approach to this at all times.
To add on this, I think it has also become more regulated in the last, I would say, couple of years. So with the onset of MDR, I mean, we're producing medical devices, and they need, claims that can be supported, and this is regulated. Where we see big differences is from, large listed companies towards also very small companies, because they sometimes fly under the radar, and they're too small that actually a lot of authorities would care about what they're saying. So I think here on our end, I think we really did our homework. We can substantiate whatever we use as let's say marketing material towards professionals, and then it also needs to be called out if there is misuse from smaller companies that actually are a bit in a gray zone what they actually can do and prove. But I think this ethical approach and also being science founded is very important for our core of the company, and how we want to be perceived and how we want to remain at the forefront in that field.
I'm very happy to hear that. No, well, I knew it, but my question was a little bit motivated by the fact that although maybe it's not the end of the story of implant, but the potential and the impact worldwide implant dentistry has had, we should be careful to flourish it and not to jeopardize it by aggressive techniques like cowboy techniques. Danny Buser called it cowboy techniques that put in discredit implant dentistry, which, can you imagine, hundreds of millions of people have still fixed teeth in their mouth thanks to this, the advent of osseointegration. And this we should never give away because it really has an impact on general health of the population. And we should be careful not to give this away. That's true.
No, thanks for the question. It's also an interesting impulse for us to think about. And I think it's a long-term game.
Yeah.
And we need to be mindful, and topics like this and cowboy approaches like this will backfire on implant dentistry, which is ultimately not a good thing. And I think it's also, we need to have an honest approach also towards topics like peri-implantitis. These topics are existing, and we need to find solutions to this also for the sake of, let's say, the long-term success for patients, but also for the whole field of implant dentistry. So that was really a good question. So thanks a lot, Urs. And we come to an end, George, to a very inspiring podcast. What stood out for you?
So for me, Urs, maybe 2 or maybe 3 things stood out very strongly for me. So first of all, it's fascinating to see how you actually bridge the, let's say, this gap or chasm between biology and technology. And your principles that you brought forward are really doing this. So it helps understanding the nature and replicating nature to the best extent that we can. And I think that was standing out for me as a guiding principle very strongly. And secondly, I think you are, let's say, having a huge legacy on your work with a lot of scholars of, let's say, people that you trained that you helped in their development as you have been helped maybe in your fantastic career.
Absolutely.
And linked to this, what also stood out to me is your gratitude. I mean, the way on how you respect other people's work, on how you want to bring together teams that can actually solve problems. That is something fantastic to see, and I think it's exactly the right approach.
No.
Thank you.
The one thing I would add is that is really impressing me, and you are a really good role model for this, also your humbleness. I mean, having such a distinct career and achievements of this magnitude over many years, and the humbleness and this combination for me is very unique, and that's something I always wanted to congratulate you for. So
thank you.
Thanks a lot for being here. This was really a big pleasure. I wish you all the best for your future, and we meet hopefully soon again. And for all the listeners, thanks a lot for joining in, for listening in. Continue to look out for the next episodes on any of the podcast players. The best way is to subscribe for the podcast, and you will be informed about the next episodes to come. And also look out for our next guests, and don't miss out to also have the opportunity to ask questions that we raise here in the podcast. So thank you, George, and thank you, Urs, for a great hour of conversation.
It's been a privilege. Thank you.
Thanks a lot, Urs.